Mice Informatics Research Conference, a special Tuesday edition. As often happens at the end of academic terms, we have a number of additional presentations of students either defending proposals or theses or dissertations. And so we have a master's thesis proposal defense today by Sarah Florig. And Sarah is a student in our Master of Science in Health and Clinical Informatics major. I've actually known her since before she joined our program because she got her first exposure to informatics in a course that Ted Ladaris and I taught at Portland State undergraduate a number of years ago. And hopefully that kindled her enthusiasm. And she did enroll in our program after she had received her Bachelor of Science degrees from Portland State in Health Studies and in General Science. In addition to being a master's student, she currently works as a research assistant in pulmonary and critical medicine with Dr. Jeff Gold, who's on her committee. Their investigations center around EHR usability, EHR training through simulated patient charts, and how the EHR influences interprofessional team dynamics. Her research interests include the impact of EHRs on the quality and safety of patient care and connections to clinical behavior. And a secondary topic of enthusiasm for her is in the reuse of EHR data for research purposes. So she's defending her master's thesis proposal today, and if she does that successfully and completes her thesis successfully, we will hear back from her in the future when she comes to actually defend her thesis. So go ahead, Sarah.
Okay, thank you, Dr. Share. Screen. Sorry, just trying to get my content shared. Okay.
There we go.
There we go. And can everyone see the slides here?
Yes, looks great.
Yes, it looks great.
Okay. Wonderful. Thanks for everyone who made it today. I'm excited to tell you more about my project. To start off, I just wanted to ask you all to think about the last time you went in to see your clinician, not when you opened my chart and went into a virtual visit, but actually went down to your office and sat in the exam room waiting to see your clinician. And I know it's been a while, but I just want you to think about who you interacted with when you went in and just how many people used a computer in the medical office. It would not surprise me at all if your clinician was one of those people. In my experience, at least, they're usually typing away madly while we're having our visit to be able to get ahead of some of the charting. Since adopting electronic health records, study after study has confirmed that clinicians are spending more and more time on their computers. Not only that, but experts agree that the effort to comply with the complex regulatory requirements, burdensome documentation rules, and the consuming demands of suboptimal tech are at the root of professional burnout. To refocus clinicians on activities that truly require their training, many organizations have begun to use medical scribes to reduce the amount of time clinicians are spending in the EHR. These assistants take real-time notes for the clinician while they're interacting with the patient. And then after the scribe completes their note, they forward it to the provider, who will go on to add the clinically relevant details that someone who's unlicensed can't. The scribes then kind of improve the clinician's workflow by decreasing their clerical burden. And many studies have previously found that they're received really well by patients and providers. While this is a popularized approach to coping with high workloads, the measurable impacts that scribes have on documentation is really challenging to gauge. Present EHR capabilities don't really have or support the use of real-time analytic tools to assess clinical documentation behaviors. And the majority of previous studies that that look at documentation completion time with scribes use self-report measures by the clinicians to assess how the scribes are able to help the clinician be more quick about completing documents. And this is really concerning because what we found is it's highly correlated to how satisfied the provider was with their scribe. And so the literature kind of leaves us with this question of, do medical scribes affect the amount of time it takes to complete documentation, and how much do they affect clinicians? And so you might not be completely familiar with the ins and outs of medical scribe use, but I think it's really, we can all appreciate the importance of having our medical records be accurate and completed in a timely manner. And if documentation is delayed for too long, it can be really challenging for recall and to get the information that belongs in the record. So some of the questions that have come up while we have been looking at this is, what does ordinary documentation completion time look like for clinicians? And then subsequently, how does the clinician's time to complete documentation change when they're working with a medical scribe? And those two things are really what we centered this project around. And so what we proposed to do with this project was describe documentation completion time across our organization. And then that would help us better understand what's going on in the general context, and then applying that to how clinicians are completing documentation when they work with medical scribes. And to do this, we extracted ambulatory records from our EHR for all clinicians who belong to clinics that have ever used a scribe. And we collected 5 years of data from the EHR on about 85 clinics. And then we calculated the amount of time to complete documentation and whether or not a scribe was present. And then we were able to get a general idea for the pattern of documentation completion in providers without scribes, and then test a hypothesis that the use of scribes do in fact improve documentation time. And so I'm going to give you some more information on this project. So before we get into it all, it's helpful to understand some of the impacts of the EHR. And so I'm going to start there. And then for those of you who don't have a clinical environment or experience in the clinical environment, I'm hoping that this part of my talk will just kind of help you understand how the electronic health record is associated with clinician burnout. I will then talk about how organizations have utilized medical scribes to combat burnout and pinpoint where the current literature falls short in evaluating scribe use. Once we understand the kind of background and setting for this research project, I'll present the project I've been working on with Dr. Jeff Gold's research group and discuss how this project adds to it and extends to help solve the gap in the literature around documentation completion time for scribe users. So the incentivized adoption of electronic health records was driven primarily by the idea that EHRs would not only improve the quality of care, but also the efficiency of the medical system. And today, over 95% of hospitals and 86% of office-based physicians have adopted some form of an EHR. And despite their promise, they have had some unintended consequences that have unfolded from their implementation. The computer plays a really large role in the patient-clinician relationship today. And in their 2012 essay, Elizabeth Toll describes some aspects of this and included this drawing, which was drawn by the artist, who is a 7-year-old girl who you can see is sitting here on the exam table. She gave this drawing to her doctor at the visit, and you can see her family is also sitting with her. They're at her visit. Unmistakably, the clinician is got his back to her and her family because he's on the computer having to type or document or use the EHR. Reviewing a patient's medical record is a major early component of a clinician's workflow in the EHR. In an ideal scenario, a few days before or the morning of a visit, the clinician has the opportunity to review the patient's record. The second major component of a clinician's EHR workflow is at the point during which the patient exam and assessment needs to be documented during the visit. Finally, the clinician must also document the care decisions as well as the diagnostic strategies and treatments once the visit has ended. And to do this, the patient sometimes needs to go through additional testing, and that those test results need to be followed up before the clinician can close the documentation. If the clinician falls behind on completing documentation, it can be difficult to find the time to go back and complete it. And OHSU has a policy that states that encounters that are closed after 14 days are considered late, and those encounters that are closed after 28 days are considered delinquent. I can barely remember what I had for dinner 2 weeks ago, let alone what I had for lunch 28 days ago. And I'm one person. I don't know how I would remember 25 to 20 to 30 people over a period of a day or two, which is, depending on your clinical schedule, how many patients you will see. And so the memory of the patient, I would assume, and of the encounter might fade, which is concerning because it'll affect how well the doctor or clinician can complete the documentation. And so you can see also in this figure that clinicians at each time point spend a significant amount of time on the computer. And if you can guess, that isn't why they went into medicine. And so the excessive data entry requirements and unnecessarily long notes that have been designed towards more billing purposes rather than patient care have been really strongly linked to burnout. And this is really not surprising considering clinicians spend more than half their day in the EHR. Recently, OHSU et al. Did a study that found clinicians are spending about 16 minutes using the EHR for every patient they see. And that is striking when you consider that the average length of a visit to see a patient is only 15 minutes. So they spend more time in the chart than they do seeing the patient. So what are we doing about it? Our like solutions, research, to combat burnout, the U.S. Department of Health and Human Services recently issued a report that aimed at shifting the focus for clinicians from the administrative requirements back to patient care. The report outlines 3 main goals. 1, to reduce clinician time and effort required to enter information into the EHR. 2, reduce the time and effort needed to meet the regulatory components and requirements. And then 3, improve the functionality and ease of use of EHRs. One way that organizations are addressing the first goal in this report, which is reducing recording efforts, is by involving additional healthcare team members to assist clinicians with certain aspects of documentation. So the main duty of the medical scribe is to listen to patient-clinician interactions and capture the relevant information that needs to be documented in the patient's record. And often after the encounter occurs, The clinician and the scribe will also work together to make sure that the documentation is comprehensive. Most medical scribes receive some formal training to develop a basic knowledge of the clinical practice and the scribing process. Some scribes, but not all of them, are directly employed by their organization, and others will contract with a scribing company who will then contract with an organization to supply scribes to the providers who want them. Several studies have shown that medical scribes could contribute to higher patient volumes, increased revenue, and higher patient and provider satisfaction. And as a result, the workforce of medical scribes has grown substantially over the past few years. Medical scribes help share much of the burden associated with documentation in the EHR, and the idea behind using them is to relieve that documentation overload that's pulling clinicians away from their patient care activities. Notice the difference in this picture here and the drawing I first showed you, where the clinician was unable to face the child or her family because they were utilizing the computer. In this image that we have with the scribe, the doctor is directly interacting with the patient and the family. The extra person improves the clinician-patient relationship because the clinician is able to provide their full attention and isn't distracted by the computer. And then scribes are also involved in a number of other activities beyond scribing in the exam room. So it's helpful for us to kind of like understand how the scribe gets involved in the clinician workload. So we're going to take a look at the workflow that we looked at without a scribe and see where the scribe kind of fits into that. So scribes are often asked to conduct pre-charting, so they reduce the amount of time the clinician spends up front in the EHR before the visit. The scribe also allows the clinician to spend more time with their patient during the exam or visit and prevents the loss of data because the scribe is capturing it real time. Once the patient leaves, the scribe can edit the final version of the note and forward it along to the physician. The clinician will add details that are important that the scribe who is unlicensed is not able to document. For example, medical decision making. And then the clinician is able to close the documentation and had only interacted with the EHR, theoretically, a minimal amount of time towards the end of documentation completion. This is a streamlined way to manage the time effort that's required to record information in the EHR and complete documentation. And studies suggest that this is well received by clinicians. However, the previous findings on how scribes impact documentation remains unclear. There are existing reports that suggest the amount of time when you have a scribe, the amount of time to complete documentation decreases, but there are other studies that say, or that find that there are no changes. And then, as I mentioned earlier, there are other studies that use these provider self-report measures to report improvements in documentation completion time. And predictably, most of those reports, there was a really strong association between provider satisfaction and the change in documentation completion. And so to date, there are only a few authors that have actually looked at documentation completion time for scribe users, and they're smaller samples with a limited number of providers or a limited number of specialties. And so like this is specifically noteworthy, I guess, because if the medical scribes are purported to improve the clinician's workflow and decrease their clerical burden, we would expect that when you use the scribe, there should be, across studies, consistent indications that they improve documentation timeliness, and that's just not the case. So the real question that still is unanswered is, when clinicians work with a medical scribe, do they complete their documentation in a more timely manner, i.e. not getting as many late or delinquent documentation closures. And so that kind of brings us to the aim of this project. Sorry. The aim of this project, which is to characterize documentation completion time among attending physicians in the absence of a medical scribe across a variety of clinical settings. For this study, we defined documentation completion time as the difference between the time the provider closed the encounter and the time at which the patient was scheduled for a visit. And then the second aim of the study was to quantify the changes in documentation completion time for physicians before and while they were using a medical scribe. Asking these questions to address these aims. So now you have a broader understanding of the impacts of the electronic health record and how we're using scribes to kind of overcome clinician burden. And so now I'm going to talk about my study and our work that we're doing with medical scribes on this project. So the OHSU Scribe program started in 2015 to support both attending physicians and advanced practice providers. The program has been extremely successful. The stats you see on the slide here are from about 2 years ago in 2018. To date, they have employed over 100 scribes across over 85 different clinics throughout OHSU, and the program has only continued to grow since these numbers were captured. This provided us a really unique opportunity to address the aims of this project, especially considering that our research group had an existing relationship with the Scribe program. The first goal of this project was to characterize documentation completion time for ambulatory encounters across the outpatient clinics that had previously utilized medical scribes. And we used a retrospective observational design to evaluate documentation completion time by clinicians in specifically the outpatient clinics that had implemented scribes at some point during the time in which scribes became available at OHSU. And we looked at how documentation completion time varied across medical specialty, across clinicians, and then also across clinics, and then across attending physicians within clinics with more than one provider who used a scribe. The second goal of this project was to quantify the changes in documentation completion for clinicians who use medical scribes. And so to do this, we applied a non-randomized control before-after study design.
Hello? I think we lost Sarah.
Yeah,
Her Wi-Fi went out.
Has the poor connection symbol on her.
Oh, is that what that means?
Yes. Yeah.
Okay, well, maybe we can give her a minute or so to get back connected.
Okay. Oh, there she is. Hi, Sarah.
Hello.
Hi, Sarah.
Hi, I'm not sure what happened, but I'm gonna just stick in on my phone.
Okay.
Because my computer. So I'm just gonna keep this audio going so we have it. Is that okay?
Yep.
Yeah, that's fine. Maybe if it comes back, you can try going back to video.
Yeah.
Okay. So the data collection process for this project has been really complex, and I have a couple of figures here that, oh, my slides might not work. Oh no.
Do you
Sarah,
want
this is
to?
Vishnu. If you email your slides to Lynn, she can
Yeah.
show for you.
Okay,
Yes.
thank you.
Okay. All right.
Okay, I'm just locating the file on my computer and pasting. I am worried that my laptop will not be able to send a file. Hold on. You know what? It's on Box, so I will forward you a link to the file on Box because
Sounds
I can
good.
do that from my phone. Man. Okay.
Hey, Sarah, your video is back.
Aha! I'm back. Okay.
Okay.
Let's try again. I'm sitting here on my phone trying to get it rolling. Okay.
There it goes.
Okay. So the process of collecting the data is really complex, and I'm going to zip through this part so that I have time to get to the rest of my presentation. But essentially, the data is collected in a clinical context, which means that it's not originally designed for research purposes. And the way we store healthcare data to make sure that the healthcare providers can access it is in a specific database that is only for essentially healthcare services. And then we make a copy of that data, and that is how researchers are able to access the data without slowing down the original database that the organization is using for servicing patients. And we had an Epic analyst write an extraction code to extract the outpatient clinic records that are specific to this study. So we were able to identify these clinics that had medical scribes previously. And so we pulled all of their ambulatory encounter records from a year before the scribe program started. And we extracted all of the characteristics on those ambulatory encounters. And we determined whether or not a scribe was present for those encounters using a historical data set that was provided by the Scribe program, and essentially used those two kind of sources to create our final sample. This is the process of transferring the data from the healthcare data set to a second copy that is easier to access for researchers. And the data transfer process is extremely messy. And so you have to be really careful when you go and you try and take out data from Clarity, that the values you're using and the things that you're trying to study are actually being represented by the variables you're using from this data. That's the short part of it. And so for these clinics, we extracted records starting in January 1st of 2014 through December 31st of 2019. And for each clinic, we extracted a bunch of characteristics about the clinic, or the encounter, excuse me, including the provider who documented the encounter, whether or not a scribe was present, the start time of the visit, the time that the provider completed the documentation, and some other descriptive characteristics such as the complexity of the case, of the bill, essentially the billing code for the visit. And in our final sample, we included office visits, procedure visits, and prenatal visits, because these were the most applicable ambulatory encounter types that we could include for this analysis. We intended to measure the difference in the start time and the completion time. And to do that, we made sure to exclude encounters that hadn't been yet closed, so they didn't have a completion time. And then because workflows may differ on the weekend, we excluded encounters that occurred on a Saturday or Sunday because there were some. And the OHSU Scribe program also services not just physicians, but advanced practice providers. And so we limited our analysis to only attending physicians because the practices of documentation might be different depending on your background and training. And then to minimize any bias that might result from the clinician not regularly working with patients, we made sure to only include a physician if they had at least 100 encounters for each year of the study period that they were included. And finally, with AIM 2, where we're looking at the pre and post scribe use differences, we only included scribe provider pairs that had at least 100 encounters to account for adjusting to the relationship and just the amount of time they spent together as a dyad. For AIM 1, the average length and variance in time to complete encounters was found, and we looked at it across medical specialties, clinics, and across clinicians, and compared clinicians within clinics we compared clinicians in clinics that had more than one provider. This allowed us to kind of understand how documentation is completed in general without the presence of a scribe. And then for AIM 2, we analyzed physicians who had encounters with and without scribes and found the differences in time to complete documentation. And for each physician, we found that for each physician, we found the differences in time to complete encounter documentation. We compared before and after scribe, and then we were able to control with peers in the same clinic at the same time who did not work with a scribe to try and account for some of the temporal things that are going on that might have affected documentation in general. So the study isn't without limitations. Some of the major limitations of the project are that it's retrospective in nature. So our data collection, it has an inferior level of evidence compared to prospective studies. It also means that our analysis is at risk of being biased. The project only includes data from a single institution, which is another limitation. It limits the generalizability of our findings. So something that's occurring at OHSU might only be occurring because it's OHSU, not because of the scribes. And so further work needs to assess this kind of document. The kinds of things we find need to be assessed at other institutions as well. And then finally, the physician interaction with the EHR and documentation hygiene is in general a really complex issue, and this project only measures really a small sliver of the relationship between scribes and providers. And so future work really needs to develop a more comprehensive model that evaluates the impacts of scribes on documentation hygiene in a way that captures the complexity of the relationship in a better way than just a single variable does. Right. So today is my proposal defense, and if I pass, I will go on to, well, we've already completed the data extraction for this project, and I did an initial data extraction at the beginning of the year, and I cleaned, verified, and analyzed that data. So the analysis files are actually already completed for this project too. Our analyst emailed me on Sunday night that all of the data for this project is available. And so I'm really excited to put my data gloves on and get started. I really enjoy that part of this. But first I needed to hear from colleagues and get some feedback about how we're approaching this project. And so after this defense, I will proceed to analyze the rest of my data. I'm hoping to have that completed by March. And then I'm hoping to have a draft that is workable by beginning of April and then defend at the end of May. And the defense date and time is already set. So if you would like an invite and you haven't received one, I'm happy to send it to you. This is a literature that I talked about in my slides, and I can send that to you if you would like a copy of that. Before I close the presentation, I just want to take a moment to recognize some important people who've been involved in making this work possible. Dr. Weiskopf and Dr. Mohan and Dr. Gold, thank you for teaching me and supporting me as a researcher and trainee. I have so much to learn from you guys, but you've all made a world of a difference in being able to carry out this project. Sky, thank you so much for all the afternoons you listened to me ramble about my project and for sharing your advice on like fitting all the pieces together and just managing it. I could not have gotten this far without you. And then finally, I want to thank the Scribe program manager, James Beckton, and I think he's here, and others who are involved in this project who I couldn't find pictures for or otherwise maybe wouldn't have fit. So here we are. It's 2021. It's almost a decade actually since Toll published this article. And health professionals are still required to divide their attention pretty heavily between patients and the EHR. Many believe that this is compromising the patient-physician relationship, and most clinicians are still spending more than half of their professional time typing and clicking and checking boxes in the EHR. Demanding documentation-related activities continue to be the leading cause of job dissatisfaction in the healthcare field. And the high rates of burnout are extremely concerning. The use of medical scribes may liberate clinicians from much of this unnecessary busy work, but it remains unclear if the documentation completion time of notes documented by scribes is actually any different than when the clinician is working on their own. So the goal of this research project really is to just help us better understand the relationship between scribe use and documentation completion time, because at the end of the day, we should be using tools and designing interventions that are able to ultimately provide better experiences to providers, and that leads to improving outcomes and patient experiences, which both deserve better. So yeah, thank you guys for all coming today, and I am excited to take some questions and have some comments or any suggestions on this project.
Great. Thank you, Sarah. I have a question actually, and then we'll have a couple kind of general comments, but I apologize if I missed this. Are you planning to, and you may not have enough data to do this, but to look at different specialties, because it may well be that certain physician specialties, by the nature of the work they do, might get more advantage from scribes than others?
It's something I'm really excited to look at. So we also did a preliminary analysis of only scribe documented encounters. And what we have found is that there's a huge variation in documentation completion. And that initially we thought that it would be, and this is just in scribe encounters, so we haven't yet looked at clinicians who don't work with scribes. But in that analysis, what we did find was that the variation is occurring at the provider level, not necessarily just the specialty level. And so the other really complex thing about this whole project that I really didn't have time to get into is it's a multi-level just there's so many factors that play into it on a multi-level system that makes it. Yeah, so to answer your question, yes, we're going to definitely be looking at specialties and documentation closure, variation, and specialties.
Yeah, that's great. The general comments, I don't want to take all your time because I know there's probably other questions, but David Bates, many of you know David Bates or know of David Bates, has said in public, I mean, scribes are here to stay, and your work is very important. But that scribes also kind of represent a failure of our EHR systems because they are so hard to get data into. That said, many of you, some of you may have heard of an initiative that's going on, funded by the National Library of Medicine. A number of institutions are involved, Columbia, Vanderbilt, called 25 by 5, which aims to reduce the burden of documentation to 25%, of which scribes may be part of that process. I've invited one of the principals to speak, and Sarah Rossetti from Columbia will be presenting to our conference on May 13th, about a week before your defense. So people may want to keep that in mind. But anyways, I don't want to take all your question time. I'm happy to open up the floor, either type into the chat box or unmute your microphone to ask any questions you have.
Hey, Sarah, great work. Thank you.
Thank you, Ben.
I have a couple questions about your methods. I'm interested, can you tell us a little more about why you decided to leave out advanced practice providers? Because it seems to me that one of your question's pretty general, like, is this worth it, and how much does Scribes improve this? So I would think that your answers would be best termed in terms of what a whole organization might invest in, which could include advanced practice providers.
That's a really good question. The sample size of advanced practice providers that have worked with the scribes with the OHSU Scribe program is really small. And so it would make it really difficult to be able to look at how it's actually impacting across the different advanced practice providers, which is really unfortunate because, as I know Joan will attest to, like, this is one of the biggest places where scribes haven't really been researched, is looking at how advanced practice providers are working with scribes, and it's really needed because they are working with them throughout all sorts of organizations, and it's definitely a limitation of this work. And I wish we had more advanced practice providers who are using scribes, because then we'd be able to answer that.
And I had two other methods questions. One, why not? Well, did you think about controlling for FTE or sort of overall clinical burden of the providers? Because it may be that providers who have less clinical load, even if they have other duties, might apportion their time very differently than providers who have a full week of clinic every week. That's number one. And then the last question I have is, it seems that it might not be too difficult to include some kind of proxy for quality or payoff in this analysis. For example, just something as simple as coding level, right? Was it the coding complexity, the 99213 for us in pediatrics, or 214 or 5, in which case you could sort of begin to suggest if there is a trade-off or something along those lines of productivity or revenue.
Those are both really good questions too. I think Dr. Weiskopf and I were talking about this yesterday, but one of the really unique aspects of this project is I'm working with metadata about healthcare, because we're not looking at blood pressure or CBCs in the records of patients. I'm looking at the information about encounters. And so it's been really difficult to capture and find the right values to measure the kinds of things we want to look at. And so I don't quite know how we would go about capturing FTE. But I think that using it could be valuable in being able to control on how much the provider is working clinically. I think that's a really important factor. And I would hope that by using just the number of encounters the provider has and kind of controlling on that helps, because that's looking at their volume of patients. But I think you're right. FTE might be a helpful variable too, in like a complementing that like number of encounters. The quality. We have CPT codes, and I will be able to hopefully control our analysis on the level of complexity, but I just haven't gotten to that point quite yet. I'm trying to design these models. The biggest challenge with this project so far has been getting the data cleaned and prepped for analysis. We don't talk about it enough, but that's like 90%, not really, it's more like probably like 70, but it's so much time to like get it all together, put it all in the right format, and then really design your analysis in a way that critically thinks about how you want to model what you're asking. And so I've jumped around between models and trying to consider which type of model to use for this analysis. And so I'm just not quite yet there to like the controlling for confounders yet, I guess, if that makes any sense.
Clearly you thought about it. Thanks so much.
Yeah, thank you.
Great. There is a comment in the chat box from Vishnu.
Yeah. I just wanted to say that, calculating FTE for clinicians in academic medical centers is often challenging. In community organizations, they typically are 100% clinical Monday through Friday. But in academic institutions, FTEs are often variable. There are competing interests like research and teaching, and the pool of clinical FTE often kind of expands and shrinks depending on their other interests also. So it becomes a little bit more challenging.
The other thing is, and it's Jeff here, Jeff Gold, is one of the advantages to what Sarah's data set is that she has a wide breadth of clinics that she's looking at, and these include specialty clinics, right? So it's not just primary care. And so when you look at certain things like whether it's even geriatrics, cardiology, a lot of these services, their clinical FTE is actually split between ambulatory and inpatient. So as well, it becomes a lot more difficult because it's not just it's not just that the only way that they could work would be with a scribe. A large amount of their FTE may be scribe independent because of that workflow is different.
And while you were saying that, Dr. Gold, I realized that one of the things I didn't add to my presentation was just like the sheer size of this data. I have millions and millions of encounters. So the 2014 data that we pulled, which was without Scribes, was about 900 and something encounters, and OHSU's total number of encounters each year increases. And so the N each year of my sample just increases. And so I have a very large data set. And I think that's another strength to this study, is that we do have a large sample size.
Good. Any other questions out there? Well, if not, thank you again, Sarah, for your interesting presentation, and we will look forward to hearing your results in May.
Okay.
So have a good day, everyone. Bye-bye.